Hello, my name is Vicky Serduke, and today we are going to go through the DSM-5 casebook and analyzing case 7, which is Michael. Michael is a 15-year-old Caucasian transgender man, meaning that he was assigned female at birth and identifies with a gender differing from the assigned one. In this case, Michael identifies as male. He reports knowing that he was male since childhood and has been facing constant resistance from his mother about his need to transition. As Michael reached puberty, he began to feel increasing gender and body dysmorphia, as he was now menstruating and growing breasts. He requested the use of puberty blockers or testosterone, but again was met with resistance. At this time of adolescence, Michael also began experiencing episodes of severe depression that impacted his friends, his schoolwork, and his relationship to himself. Michael's mother agreed to take him to therapy and allowed him to wear binders. However, she still refuses to allow Michael to go on testosterone treatments due to a fear of unknown side effects. She also calls Michael his dead name, or the name that he was given at birth. Still feeling invalidated and severely depressed, Michael attempted suicide. After this, Michael's mother allowed him to legally get his name changed. And that's the case that the DSM-5 casebook gave us. So we're going to see what we know about Michael and his situation utilizing the Hayes addressing model. The model allows us to see target and agent ranks, or privileged and oppressed identities, that a person may have. Understanding where a person sits in the social hierarchy of their culture allows us to understand a few more factors that may not be listed in paperwork or diagnostic criteria that would affect a person and their symptoms. Okay, so A is for age. We know that Michael is 15. Now, as a 15-year-old, Michael is a minor, which means that he is a target due to his lack of rights and legal power. His mother is the one who has the final say on his health care and well-being. Now, we don't know which state this is happening in, so we aren't sure of the age of consent. In the state of Washington, minors over the age of 13 who are deemed competent are allowed to consent to psychological care without parental approval, and this is according to the RCW, Revised Code of Washington, Title 71, Chapter 17.34, Section 71.34.500. However, just because he can consent to psychological care, he is still not allowed by law to consent to non-emergency medical treatment unless the mature minor doctrine is applied. Because the DSM-5 casebook does not specify whether he is using the mature minor doctrine or not, we're going to not include it as it is not something that is typically common. So, in essence, by being 15, Michael's mother has the power to make the final say in his medical decisions. Now, going down the addressing model, we're going to look at the D. We do not know if Michael has a developmental or acquired disability. And for R, we aren't sure of his religion. For race and ethnicity, we understand that Michael is Caucasian, which means that he oftentimes will be considered white presenting. Being born with light skin is considered being in a privileged position. So we know that a lot of the issues that Michael is facing most likely aren't because of his whiteness. However, this does not account for race, as a lot of people who are Caucasian may have darker skin or come from more Middle Eastern environments where they would face severe stigma in the United States. But we're not sure, so we're just going to leave it as his ethnicity is Caucasian. So the next identity down the list that we can look at is sexuality. We don't know Michael's sexuality or anything about that, and so we're not going to include it. Also, as Michael is a minor, we don't want to assume any sexual orientation or sexual activity. Next is socioeconomic class. We don't really know what socioeconomic class he falls into. But we do know that his mother is able to afford a binder, as well as therapy for Michael and family sessions. Being in the middle class would put Michael in the position of an agent, but we can't be sure where he stands. All we know is that he has access to therapy as well as family therapy with his mother. He is also able to afford a binder through his mother's finances. This does not define socioeconomic class or standing, but it does give us a good insight that he is not on the lowest end of the poverty scale. Next, we have Indigenous status and nationality. Once again, there is no hinting or disclosure by the DSM-5 casebook about this status. We don't know whether he is related to anyone indigenous or if he is a part of any tribe, nor do we know if he comes from a different country. So we're not going to make assumptions. Lastly, we know that Michael is a transgender man, with the G in addressing model standing for gender. This part gets a little bit complicated. Being assigned female at birth would have put Michael into the position of a target, and disagreeing with assigned gender, being trans, is also something that can be targeted. The gender that he identifies with, man, tends to be a privileged status. So we are facing a bit of conflicting information. However, another aspect of this is the concept of passing, which may allow a transgender or a non-binary person more privileged in a heteronormative, patriarchal society. But we don't know Michael's standing in that regard. We don't know if Michael is passing or if he even wants to. And even the concept of passing can be problematic in that it insinuates that a person has to fit under a certain status quo in order to be acceptable and face privilege that they would. Okay, so going down the addressing model, we understand just a bit more about Michael. So let's see what the casebook has to say about his diagnosis. So, the DSM-5 casebook came to the conclusion that Michael suffers from gender dysphoria in adolescence, persistent depressive disorder with an early onset, along with intermittent major depressive episodes, and a severe parent-child relational problem. So, starting from the top of that list, adolescent gender dysphoria. Adolescent gender dysphoria includes the need and desire to identify as a gender other than assigned at birth. People who experience gender dysphoria may find themselves altering their appearance and feeling uneasy about their own sex characteristics, both primary and secondary. They may wish to change them or attempt to remedy their appearance. In addition to these symptoms, a person must also find disruption in their lives because of this. This has to be a problem in their lives for it to be considered worthy of a diagnosis. This will be discussed about later. So, some of the issues that Michael says he has are that he lost motivation, friends, and felt severely depressed due to his inability to truly be himself as a man. His requests for testosterone binders and a name change can bring us to the conclusion that he can be diagnosed with adolescent gender dysphoria that was early onset due to him presenting the symptoms from the age of 7. Next, the casebook came to the diagnostic conclusion that Michael has persistent depressive disorder, or dysthymia, which is the experience of one or more years for adolescents and 2 or more years for adults of a mostly depressed mood, low self-esteem, feelings of hopelessness, and other symptoms. Now, Michael has suicidal ideation and has attempted suicide, which is classified under the DSM-5 as major depressive disorder, not persistent depressive disorder or dysthymia. However, other criteria under dysthymia for adolescents have been met for at least a year. So we can say that Michael suffers from persistent depressive disorder as well as episodes of major depressive disorder that have been severe. So, as the casebook puts it, early onset dysthymia with major depressive episodes. So that checks out. Next, the casebook gives him the diagnosis of severe parent-child relational problem. And going through the DSM-5, while this is considered a condition that may be a focus of clinical attention, it is not technically a mental disorder. Nonetheless, it is important to understand Michael's upbringing and current relational standings with his caregiver, as well as past relationships. This can help inform the practitioner or counselor of certain attachment styles, temperament, traumas responses, and patterns. Being aware of the parent-child relational problem also gives us insight into his surroundings, where he is outside of the therapy room, and what can be done in order to improve his symptoms and make him feel better with a surrounding that may not be as supportive. So, all of these 3 diagnoses that the DSM-5 casebook has assigned, check out. However, the DSM-5 and the DSM-5 casebook present very westernized views. These views are patriarchal, are in support of the white supremacy, and are heteronormative, sexist, racist, and incredibly problematic. That being accounted for, all of the different identities that Michael could have that aren't listed by the casebook could really change the way that treatment is addressed for him. For example, going down the addressing model, we're going to go down to R for religion. If Michael was incredibly religious, there may be moral objections to medical treatment that isn't life-threatening. So, other non-medical alternatives to treatment may have to be considered. That is, if his identity is accepted at all by the religious community. For example, in Judaism, the Torah, or the First Amendment, for those who aren't Jewish, it states that dressing as the other gender is prohibited. And so any attempts at coping with gender dysphoria that a person does could be punished, whether it be corporal punishment or general stigma and shunning of the person. In addition, certain minors of religious upbringings have been forced into conversion camps that attempt to fix someone's LGBT status, and has been shown that it just causes more trauma. So as we can see, a single identity shift can really change the way that a person experiences symptomology. And so not knowing that really impacts what we understand about Michael and how treatment should continue. So let's say Michael was white presenting, meaning that he was Caucasian and perhaps had a family member who wasn't. So let's say he was white presenting and that he was white, but actually had familial heritage of a Native American tribe, such as the Lakota. And the Lakota people are more accepting of non-binary gender roles and also utilize the concept of two-spirit, such as many other Native American tribes do. The concept of two-spirit shows that a person can be more than simply man or woman and can be outside of gender roles and the binary. This is often an accepted role and even esteemed at times in certain tribes and cultures. So let's say that Michael did have Native American heritage. That would put him in a target role, as an Indigenous people often face stigmatization and lots of repercussions due to colonization and the taking of their land and culture. There may be cultural differences in values, in body language, in general, that could cause clinicians and practitioners to misunderstand Michael and his experience and also result in mistreatment. So Just a single identity can greatly change the way that a person can experience medical care. And when these identities begin to intersect, their intersections also change the play that goes into medical care. And there are a lot of intersecting identities and cultural identities that aren't accounted for in Michael's case through the DSM 5 casebook. And each one of those would greatly impact treatment. In general, however, even with what Michael is experiencing with his known identities, those that experience gender dysphoria face intense stigma, and that can be a block to uh, receiving medical treatment, as well as institutionalized blocks. An institutionalized block, for example, would be insurance denying a person care should it be a religious insurance provider, or one that does not believe in gender reassignment or gender therapy. Certain employment that provides insurance is allowed to say that they will not willingly provide gender reassignment or gender therapy, which can be seen in different legislative actions that are being taken. Whether or not they are passed, the effort is still there, which really shows the fact that there is a stigma and a distaste for those who face gender dysphoria. And in addition, certain places and cultures don't even believe that gender dysphoria is a medical condition, in the terms that gender assignment is natural and any deviation is a choice and unnatural and can be fixed. Others believe that gender dysphoria isn't a medical necessity because gender identity and the gender binary as concepts are problematic. Utilizing Foucault's theories of language and the power that language holds, simply giving it the name gender dysphoria gives it a stigma, gives it the name that, hey, this is not normal. That being said, there are changes from the DSM 4 to the DSM 5 that do allow more of an open space for this type of understanding of gender dysphoria. The DSM 4, which was used up until 2013, didn't have gender dysphoria. Instead, it was gender identity disorder. Already, the name of disorder versus dysphoria is incredibly pathologizing. Next, they talk about the gender binary. Instead of acknowledging that there are sexes and genders other than the female and male typical narrative, they also state the DSM 4 only states that there's those two. So, for example, some of the criteria are repeatedly stated desire to be or insistence that he or she is the other sex. In boys, preference from cross-dressing or simulating female attire. In girls, insistence on wearing only stereotypical masculine clothing. Strong and persistent preference for cross-sex roles and make-believe play, or persistent fantasies of being the other sex, along with a few other things. Immediately, we can see that this is definitely a bit more of a pathologizing and stigmatizing diagnosis. It not only reinforces the gender binary, it also invalidates the struggle that a person may have, citing it as fantasies and make-believe play, whereas the DSM-5 acknowledges that this is a real condition and experience. This does lead me to being curious about what the future may hold for those who aren't the gender that they are assigned at birth. I also wonder about the whole concept of assigning gender and sex at birth, as there are a lot of cultures that don't see genitals as the marker of gender. Not only that, there are people who are born with intersex physical traits and genetics that are outside of a typical gender binary. They are not 100% penis or 100% vagina, as medical institutions have said is the definition before. And genetically, we may have differing genetic pairs and chromosomal pairs other than the XXXY binary. In opening up those definitions and opening up the cultural understandings of what gender is, I wonder if gender dysphoria is going to continue to be a diagnosis in the DSM-5 in a culture, hypothetically, where gender isn't a binary and is more fluid and freeform, and expression through clothes, through actions, and through many other things is seen as fluid and just a way for a person to express themselves in the moment that they are in. In cases like this, would gender dysphoria still be a diagnosis? Or would it be a natural part of a lot of people's lives that they can work with? Would gender reassignment surgery and hormone treatment be more easily accessible to those who are understanding of their own experience, with medical practitioners who are more open to understanding this? Short answer is, I don't know. Long answer is, I absolutely have no idea. It depends on future research and what is going to continue to happen through legislation and cultural norms. As for the case of Michael, we know that he struggles with gender dysphoria as it impacts his social life, his relationship with his mother, and his schoolwork. So it is something that we want to help. And by allowing him to express himself in a way that feels comfortable, perhaps these symptoms would be reduced and he would find himself living a more enjoyable life. We don't know that, though. This is a hypothetical case created by someone in a way to practice DSM-5 criteria. So we don't really know whether this worked, nor do we know how it would look should certain identities be changed. However, what can be said with certainty is that the DSM-5 only addresses Michael's age and his skin color and his gender and sex. There are so many other things unaccounted for that could greatly impact treatment that are simply thrown away or not mentioned by the DSM-5 casebook. And so I ask myself and I ask other people to look into the future. What can we see with diagnostic criteria? How can it be damaging to others? And how can treatment be used in a way that is not only empowering and helping with the relief of symptoms, but also a way for people to truly be themselves without the push of a social narrative? Who knows what that'll look like? Maybe something nice.